current
Recording in
screening
progress.
practices and the potential role of clinical support tools in addressing that. Second, we'll work through the practical case-based diagnostic approaches. Finally, we'll discuss evidence-based treatment strategies and monitoring. Current
Recording in
screening
progress.
practices and the potential role of clinical support tools in addressing that. Mr. EB is a Second, we'll work 28-year-old through man the with practical
E
case-based diagnostic approaches. Past medical history
Finally,
of
we'll
atrial
discuss
fibrillation.
evidence-based
Blood
treatment
pressure
strategies
remains
and
uncontrolled on
monitoring.
2 antihypertensive medications, though reports
Current recording in progress and the potential role of clinical support tools in addressing that.
Mr. EB is a
Second, we'll work through the practical case-based diagnostic approach.
It can arise from a single or multiple aldosterone-producing regions in one or both adrenal glands. Studies over the last decade has informed us that primary aldosteronism is largely a genetic disorder. More than 90% aldosterone-producing adenomas carry somatic mutations. And these key mutations are found in the genes like KCNJ5, CACNA1D, and others. And irrespective of
Finally, we'll discuss evidence-based treatment strategies.
it can arise from a single or multiple aldosterone-producing regions in one or both adrenal glands, leading to autonomous aldosterone production. Studies over the last decade has informed us that primary aldosteronism is largely a genetic disorder. More than 90% aldosterone-producing adenomas carry somatic mutations. Leading to and these key mutations are found in the genes KCNJ5, CACNA1D, and others. Leading to increased absorption of sodium.
Irrespective of finally, we'll discuss evidence-based treatment strategies. It can arise from a single or multiple aldosterone-producing regions in one or both adrenal glands, leading to autonomous aldosterone production. Studies over the last decade has informed us that primary aldosteronism is largely a genetic disorder. More than 90% aldosterone-producing adenomas carry somatic mutations. And the KCNJ5, CACNA1D, and others, and increased absorption. Irrespective of it can arise from a single or multiple aldosterone-producing regions in one or both adrenal glands, leading to autonomous aldosterone production. Studies over the last decade has informed us that primary aldosteronism is largely a genetic disorder. More than 90% aldosterone-producing adenomas carry somatic mutations.
The data seems to be consistent. About 20. Those that are represented in the red and blue graph are those who have underwent adrenalectomy. And this group, whether they had hypertension cured or not, had all lower all-cause mortality compared to those with primary or essential hypertension, represented here in the orange line. So going back to the earlier question, the young age at onset or the onset of hypertension at a young age, early onset unexplained atrial fibrillation are indications for screening for primary aldosteronism in this individual. The normal potassium does not exclude primary aldosteronism, and current medication and adherence needs to be addressed, but that should not delay primary aldosteronism screening. But the reality for this individual and most others is primary aldosteronism diagnosis is reached, if at all, after people have developed.
Those that are represented in the red and the blue graph are those who have underwent adrenalectomy, and this group, whether they had hypertension cured or not, had all lower all-cause mortality compared to those with primary or essential hypertension, represented here in the orange line.
This is a best
So
practice.
going back to the question, earlier question, the young age at onset of hypertension at a young age, early onset unexplained atrial fibrillation are indications for screening for primary aldosteronism in this individual. The normal potassium does not exclude primary aldosteronism, and current medication adherence needs to be addressed, but that should not delay primary aldosteronism
Another
screening.
study here which targeted treatment-resistant hypertension.
But the reality for
that
this
the
individual
primary
and most
aldosteronism
others is
screening
that primary
orders placed on
aldosteronism
the
is
y-axis
diagnosis is
doubled
reached, if at all, after people have developed. Those that are represented in the red and the blue graph are those who have underwent adrenalectomy, and this group, whether they had hypertension cured or not, had all significant lower all-cause lethality compared to those with primary or essential hypertension represented here in the orange line. This is a best. So going back to the question, earlier question, the young age at onset of hypertension at a young age, early onset unexplained atrial fibrillation are indications for screening for primary aldosteronism in this individual. Normal potassium does not exclude primary aldosteronism, and current medication adherence needs to be addressed, but that should not delay primary aldosteronism screening.
Here which targeted treatment-resistant hypertension.
But the reality for this individual and most others is that primary aldosteronism is diagnosis is reached, if at all, after people have developed. Those that are represented in the red and the blue graph are those who have underwent adrenalectomy, and this group, whether they had hypertension cured or not, has had all significant lower all-cause lethality compared to those with primary or essential hypertension represented here in the orange line. This is a best. So going back to the question, earlier question, the young age at onset of hypertension at a young age, early onset unexplained atrial fibrillation are indications for screening for primary aldosteronism in this individual. Normal and current medication adherence needs to be addressed, but that should not delay primary aldosteronism screening. Here, which targeted treatment-resistant hypertension. Whether they had hypertension cured or not, has had all significant lower all-cause lethality compared to those with primary or essential hypertension represented here in the orange line. This is a best. So going back to the question, earlier question, the young age at onset normal
working. So let's proceed. So in this study, which checked aldosterone levels multiple times among people with confirmed primary aldosteronism, showed that the aldosterone levels were below this traditional cutoff of 10 nanogram per deciliter or below in 14% of this cohort. Another cohort also shows 29% of primary aldosteronism patient confirmed PA patients had aldosterone levels below the traditional screening method threshold.
This is a best question, earlier question, the young age
study which looked at the established prevalence at the different stages of hypertension using 24-hour urine collection. 24-hour urine aldosterone levels. So in this study, we checked aldosterone levels multiple times among people with confirmed primary aldosteronism and showed that the aldosterone levels were below this traditional cutoff of 10 nanogram per deciliter or below in 14% of this cohort. Another cohort also shows 29% of primary aldosteronism patient confirmed PA patients had aldosterone levels below the traditional screening method threshold. Confirmed primary aldosteronism show that the aldosterone levels were below this traditional cutoff of 10 nanogram per deciliter or below in 14% of this cohort. Another cohort also shows 29% of primary aldosteronism patient confirmed PA patients had aldosterone levels below the traditional screening method threshold. These cutoffs aim to balance diagnostic sensitivity with practical clinical implementation, particularly as screening becomes widely available. However, as studies showed earlier in the earlier slides, even these screening thresholds have limitations. Therefore, if clinical suspicion for primary aldosteronism remains high despite initial negative testing, repeat screening is warranted. As with any medical condition, interpretation of biochemical results should also consider or take into account the pretest probability of disease. Aldosterone levels were below this traditional cutoff of 10 nanogram per deciliter or below in 14% of this cohort. Another cohort also shows 29% of primary aldosteronism patient confirmed PA patients had aldosterone levels below the traditional screening method threshold. Cutoffs aim to balance diagnostic sensitivity with practical clinical implementation, particularly as screening becomes widely available. However, as studies showed earlier in the earlier slides, even these screening thresholds have limitations. Therefore, if clinical suspicion for primary aldosteronism remains high despite initial negative testing, repeat screening is warranted. As with any medical condition, interpretation of biochemical results should also consider or take into account the pretest probability of disease. Aldosterone levels were below this traditional cutoff of 10 nanogram per deciliter or below in 14% of this cohort. Another cohort also shows 29% of primary aldosteronism patient confirmed PA patients had aldosterone levels below the traditional screening method threshold. Cutoffs aim to balance diagnostic sensitivity with practical clinical implementation, particularly as screening becomes widely available. However, as studies showed earlier in the earlier slides, even these screening thresholds have limitations. Therefore, if clinical suspicion for primary aldosteronism remains high despite initial negative testing, repeat screening is warranted. As with any medical condition,
Repeat screening is warranted here in us with any condition
earlier that even though the traditional aldosterone cutoff is 10 for case detection, studies demonstrated hourly bursts of aldosterone secretion with levels falling below 10 in 20 to 30% of cases. Therefore, the likely diagnosis in this individual is primary aldosteronism. In this case, we proceeded with a 24-hour collection for aldosterone, which confirmed the diagnosis of primary aldosteronism. So case 3, a 56-year-old male with hypertension, hypokalemia, 5 classes of antihypertensive medications. Laboratory findings show renin activity of 0.1, plasma aldosterone concentration 28 nanogram per deciliter, and conventional units both, and then serum potassium low at 3.2. CT adrenal
screening is warranted here in us with any condition
that even though the traditional aldosterone cutoff is 10 for case detection, studies demonstrated hourly bursts of aldosterone secretion with levels falling below 10 in 20 to 30% of cases. Therefore, the likely diagnosis in this individual is primary aldosteronism. In this case, we proceeded with a 24-hour collection for aldosterone, which confirmed the diagnosis of primary aldosteronism. So case 3, the Endocrine Society, a 56-year-old male with hypertension, hypokalemia, 5 classes of antihypertensive medications. Laboratory findings show renin activity of 0.1, plasma aldosterone concentration 28 nanogram per deciliter, and conventional units both, and then serum potassium low at 3.2. But in all other
screening is warranted here in us with any
that even though the traditional aldosterone cutoff is 10 for case detection, studies demonstrated hourly bursts of aldosterone secretion with levels falling below 10 in 20 to 30% of cases. Therefore, the likely diagnosis in this individual is primary aldosteronism. In this case, we proceeded with a 24-hour collection for aldosterone, which confirmed the diagnosis of primary aldosteronism. In their cohort, they report
case 3, the Endocrine Society, a 56-year-old male with hypertension, hypokalemia, 5 classes of antihypertensive medications. Laboratory findings show renin activity of 0.1, plasma aldosterone concentration 28 nanogram per deciliter, and conventional units both, and then serum potassium low at 3.2. But in all other that even though the traditional aldosterone cutoff is 10 for case detection, studies demonstrated hourly bursts of aldosterone secretion with levels falling below 10 in
for primary aldosteronism. And a systematic review and meta-analysis, which included 55 studies. First, they show the evidence that use of confirmatory tests in a setting of high probability or feature of primary aldosteronism is based on very low quality evidence. Further, they even the clinical impact being, they mentioned that use of confirmatory tests led to excess missed cases. And they conclude that the use of confirmatory tests should be reconsidered for patients with high probability of primary aldosteronism features and abnormal screening results. Another study which followed patients with negative confirmatory tests for up to 5 years report that about 1/5 or 20% of patients with a negative confirmatory test develop overt primary aldosteronism over time, primary aldosteronism over time. So the guideline has already outlined that when aldosterone is above 20 in a setting of suppressed renin, low potassium, we don't need additional confirmatory tests. But studies has also challenged the role of confirmatory tests in a setting of strong clinical features plus abnormal screening test results, or when we have high screening values. But most importantly, a negative confirmatory test result does not exclude primary aldosteronism definitively. And if clinically indicated, if clinical presentation deteriorates, we need to think about rechecking. Or as a management option, we should consider mineralocorticoid antagonist therapy again in a setting of all those renal-resistant hypertension, low renin, or probable primary aldosteronism. After primary aldosteronism diagnosis, adrenal imaging is recommended, and older studies show that imaging studies correctly identify the source of the aldosterone excess or primary aldosteronism of 50% of the time. Even a more recent systematic review reports sensitivity and specificity of 68% and 57% respectively. They add further that even in young patients, 21% risk of unnecessary surgery if relying on imaging alone. So the key point here is adrenal venous sampling remains the gold standard for surgical decision-making and management of primary aldosteronism. Adrenal venous sampling involves catheterization of the bilateral veins and the inferior vena cava, and then the first step is verifying correct placement of the catheter by looking at cortisol step-up or selectivity index. In the case of ACTH stimulation, if the cortisol is 5 times more than in the adrenal veins, more than the periphery, we say the catheters are at the right place. And then we look at lateralization by looking at aldosterone to cortisol ratio on each side of the adrenal veins. And in the case of ACTH stimulation, if the ratio is 4 or more, we say that it has lateralized to one side. And then further, we look at contralateral suppression by looking at aldosterone to cortisol ratio on the contralateral side compared to the periphery. And if it is less than 1, it suggests contralateral suppression. There are emerging approaches in primary aldosteronism subtyping, one of them being metomidate PET-CT scan versus adrenal venous sampling. In this study, looking at biochemical success and clinical success rate provided here right in the middle, they report that metomidate was non-inferior to adrenal venous sampling, so we might be seeing some other options of subtyping down the line. So going back to case 3, what is the best next step? A, proceed with dynamic confirmatory testing. That is not the best next step, as aldosterone is clearly very high in a setting of suppressed renin and low potassium, as we've seen earlier. Second, it says stop interfering medications and repeat. This is not the best next step because most antihypertensive medications cause false negative results, but this individual has positive results despite multiple medications that are causing false negative results. So further just checking by stopping medication not indicated. C, diagnose bilateral primary aldosteronism. This assumes bilateral disease, which is not correct. CT findings alone are insufficient for making this conclusion. They cannot determine lateralization. We cannot determine lateralization from imaging only. And then the best next step in this individual would be the proceeding with adrenal venous sampling if surgical management is indicated as desired. I'll move to my last objective here: outline evidence-based treatment options and monitoring protocols. So unilateral laparoscopic adrenalectomy is recommended for confirmed lateralizing disease. Preoperative optimization of blood pressure and potassium are recommended. And the treatment with mineralocorticoid antagonists prior to surgery serves 2 purposes. One, it will help to achieve blood pressure optimization biochemical control of potassium and other values. Secondly, it informs post-surgical outcome based on the response to the mineralocorticoid antagonist. Post-operatively, we discontinue mineralocorticoid antagonist after surgery and monitor potassium for a few weeks due to a risk of transient hyperkalemia due to hypoaldosteronism. And we adjust other antihypertensive medications based on the blood pressure response we see clinically in the subsequent days or during hospitalization. The primary aldosteronism surgical outcome group suggests follow-up of patients to assess clinical outcome and biochemical outcome within 3 months and then 6 to 12 months later. And they have clinical outcomes are established by looking at blood pressure measurements and use of antihypertensive medications. And we say there is complete clinical remission if blood pressure is at goal in a setting of no antihypertensive medication. Biochemical outcome looks at potassium, renin, and aldosterone measurements. And if all these values are within the normal range, we say complete biochemical remission. So we're going back to case number 3. He has lateralizing adrenal venous sampling to the left and is being referred for left adrenalectomy. But he's asking, what is my chance of having complete clinical success or remission? A, 30 to 40%, B, 55 to 60%, C, 60 to 70%, and D, more than 80%. So this is a study which looked at clinical and biochemical success rate after adrenalectomy, and using 705 cohorts, they report complete clinical remission in 37% of their cohort and complete biochemical success in 94%. More recent data reports complete clinical success for of 39%. Therefore, we should advise this individual that his chance is 30 to 40%. And setting this expectation prior to surgery is helpful. What are predictors of favorable surgical outcomes or clinical predictors of cure? Young age, female sex, lower BMI, but most importantly, short history of hypertension, absence of vascular remodeling, and chronic kidney disease are predictors of complete clinical remission. Again, highlighting the importance of early intervention. The international consensus classifies histopathology into 2 broad categories. Classical histopathology involves when the the classification is using the morphologic examination and the CYP11 beta-2 immunochemistry staining. The classical refers to the CYP11 beta-2 activity in one area in the form of adenoma, microadenoma, or hyperplasia, whereas non-classical refers to multiple areas of activity, the CYP11 beta-2 activity in the form of microadenoma or hyperplasia. And studies show that histopathology informs outcome. And this study of 60 patients with primary aldosteronism, they report that those with classical histopathology had 98% biochemical success rate, whereas those with non-classical had 67%. And another study which looked at long-term recurrence, they report 23% recurrence among their cohort. And further, they classify that the most of this recurrence out of which 60% happened in the classical histopathology after a follow-up period of 9 years. A more larger study of 262 primary aldosteronism patients first reports that no biochemical remission. First, they report in 16% of their cohort. This was after the fact that all had lateralization index of 4 or above. And then they showed that this no biochemical remission happened in 73% had multiple CYP11 beta 2 positive areas. So non-classical histopathology based on the current data has higher disease persistence and recurrence, which suggests long-term monitoring. So this is a case we saw earlier with resistant hypertension and hypokalemia, had primary aldosteronism confirmed, adrenal venous sampling showed non-lateralizing result, and medical treatment was started. Before primary aldosteronism diagnosis, amlodipine 10 milligram, benzapril, chlortalidone, all at optimal doses, and high-dose potassium. After diagnosis of primary aldosteronism, currently on spironolactone 100 milligram and amlodipine 10 milligram daily. And then we see the blood pressure parameter before and after here has improved. Renin activity 0.2, and potassium has normalized to 4.3 from 3.2, and GFR has dropped from 81 to 57 here. Question asks, what is the next best step? Reduce spironolactone due to GFR, reduce GFR, no medication adjustment needed. Increase spironolactone dose and reduce amlodipine. Stop spironolactone due to reduced GFR. So medical treatment of primary aldosteronism involves first dietary salt restriction, which leads to decrease in the sodium delivery to the distal nephron, thereby limiting the INAC-mediated sodium absorption, reabsorption rather, and also blocking the mineralocorticoid receptor antagonists using spironolactone or eplerenone. Spironolactone is a non-selective mineralocorticoid antagonist. It's long-lasting, it's cheaper, and it has more effective blood pressure control than eplerenone based on an older randomized control trial. Eplerenone is more selective mineralocorticoid antagonist. It has to be dosed twice daily because of its lower plasma protein binding affinity. When we start medication and up titrate doses, it is recommended to monitor potassium, particularly in a setting of renal impairment. If hyperkalemia develops during treatment course, we have the option to stop the other antihypertensive medications which causes hyperkalemia, like angiotensin receptor blockers or ACE inhibitors. Option of adding loop diuretics, or adding SGLT2 inhibitors based on current recent data, or using a potassium binders. If there is intolerance of this medication, amiloride can be used, which blocks the epithelial sodium channel and prevents reabsorption of sodium. However, there is no cardiovascular protection when using amiloride. And there are medications under investigation, particularly the aldosterone synthase inhibitors, which blocks the CYP11 beta 2 mediated conversion of 11-deoxycortisol to aldosterone. So we might have more options down the line. So in this study, which looked at the incidence of atrial fibrillation and mineralocorticoid receptor activity in patients with medically and surgically treated primary aldosteronism, they show that the incidence of atrial fibrillation was higher among those medically treated with mineralocorticoid antagonists, but their renin remained suppressed, represented here by the orange graph, compared to those, for example, renin is no longer suppressed. And similarly, another study looking at cardiovascular incidence of or cardiovascular events similarly demonstrate that those treated medically, but renin is still suppressed, had a higher cardiovascular events compared to those renin is no longer suppressed or essential hypertension, primary hypertension group. So the key point here is if renin is remained suppressed, that's a proxy for insufficient mineralocorticoid blockade. And in these two cases, this group had a significant higher risk of incident cardiovascular events and atrial fibrillation. Another a more recent study, a Swedish nationwide study, which had 2,400 plus patients with primary aldosteronism, they report increased risk of cardiovascular mortality and cardiovascular mortality and all-cause mortality among those with this higher listed out here. But among that was they treated with low-dose mineralocorticoid antagonists. Those treated with higher doses mineralocorticoid did not have that increased risk of cardiovascular and all-cause mortality. Therefore, being on mineralocorticoid antagonist by itself is not enough in preventing morbidity and mortality in this patient population. Therefore, the parameters of follow-up when we're treating medically are normalizing blood pressure within the target range. Also, looking at normal potassium without supplement and targeting a non-suppressed renin level. So in this individual, breaking it down further, so blood pressure, key clinical findings are blood pressure has normalized, but renin has remained suppressed. And we've seen that that's an indication or a proxy for inadequate mineralocorticoid receptor blockade and risk of increased cardiovascular morbidity and mortality. So we need to increase the spironolactone dose. We see that the blood pressure already has normalized, so we have to create a room by reducing amlodipine. Actually, when we have primary aldosteronism patients on targeted treatment approach like this, typically this allows us to reduce or eliminate other antihypertensive medications, ultimately decreasing the overall medication burden. I find it rewarding actually this way. And it not only simplifies the treatment regimen, but reduces medication-related side effects and improve patient adherence. Other options reduce spironolactone due to reduced GFR or stop spironolactone due to reduced GFR are not the best next step because we've after initiating treatment for primary aldosteronism, medically or even surgically, one of the things actually that improves is or normalization of this hyperfiltration state because excessive aldosterone was driving abnormally high filtration rate. And then when we block the action of aldosterone with mineralocorticoid antagonist or even after surgical treatment, there is unmasking of underlying kidney impairment that was previously masked by the aldosterone-mediated hyperfiltration. So understanding this mechanism helps why the GFR decline is unexpected finding and should not be necessarily interpreted as treatment-related kidney injury. Therefore, A and D are not the best next step. And then clarifying this actually outright with patients is helpful. And then B is not the best next step, no medication adjustment as we've seen earlier. So we have a critical, clinical, and even public health gap. Less than 2% of high-risk patients for primary aldosteronism are screened for primary aldosteronism. I think best practice alerts show potential to enhance screening. It's one option as one option. Screening considerations should take into account that there is intra-individual aldosterone variability. So if screening is negative, particularly in a setting of high clinical suspicion, we have to repeat screening. Confirmatory testing is not needed when the classic triad of aldosterone above 20 and low renin and suppressed renin, but even current evidence challenges among those strong clinical features plus abnormal screening or high screening values if we need confirmatory testing. But most importantly, negative confirmatory testing does not definitively exclude primary aldosteronism. And at every step of our diagnostic workup, we can have the use of mineralocorticoid antagonists and titrating that as a management strategy, and not a negative screening test result or negative confirmatory test in a setting of particularly resistant hypertension, low renin, or probable PA, mineralocorticoid antagonist, and based on the recent data, even titrating up to other target non-suppressed renin might be the best next step. Adrenal venous sampling remains the gold standard. If there's no laterality or non-lateralizing disease is treated medically with spironolactone and pleuronan along with salt restriction. And medical treatment titrate to optimize blood pressure, potassium, and non-suppressed renin to ensure adequate mineralocorticoid receptor blockade and reduce morbidity and mortality. And then complete clinical remission after surgery does not happen for majority based on the current data. But favorable predictors for complete clinical remission are short history of hypertension and absence of vascular remodeling and absence of CKD, again, taking us back to let's identify patients early for targeted treatment. Histopathology informs long-term prognosis and monitoring. Thank you. And questions here, I will open up. I will read the first question. How do you manage someone with labs concerning for primary aldosteronism but no hypertension? Example, screening in patient with unilateral adenoma. Currently, I think it's my understanding that we don't have data in this group if treatment actually is helpful. Therefore, in those group, I would not, there's no data to suggest that treatment has an impact. How long should an MRA be held, and are any other medical adjustments necessary in order to diagnose primary aldosteronism on labs? And honest, we can actually screen patients without discontinuing any antihypertensive medications. In fact, we can do most of the workup without discontinuing antihypertensive medications as long as renin is suppressed. And because most people are on low dose mineralocorticoid antagonists anyway, we find that renin is suppressed in most. So I would screen without adjusting antihypertensive medications. But if screening is negative, then in that case, I will hold the most offending medications, mineralocorticoid antagonists or diuretics, for 2 to 4 weeks and then screen again. And during that time, we can use alpha blockers, hydralazine, or calcium channel blockers as an alternative to management. How to counsel patients regarding surgery versus medical management. I'm not sure if I'm going in the right order, but how to counsel patients regarding, I think there is clear evidence that for lateralizing disease, if there is no contraindication to surgery, undergoing surgery is the best next step. That is our current understanding. Even though there's no direct, well studied randomized control trial comparing the two. that's how I will pose the discussion. Let me see, going back to the actually. Thank you so much. Okay, and then how can we interpret cortisol in adrenal venous sampling in patients with cortisol co-secretion? So there is a recent data actually support. So if in a setting of mild autonomous cortisol secretion, that the adrenal venous sampling can be performed, and also the lateralization, or in other words, it should not affect the interpretation of adrenal venous sampling, particularly as long as DHA sulfate is not suppressed, or and ACTH is not suppressed. I'm considering that you're talking about the mild cortisol secretion in a setting of primary aldosteronism. Up to 20 to 25% can have mild autonomous cortisol secretion. And in that group, based on recent data, that we can still interpret adrenal venous sampling results is how I look at it. Can you clarify the role of 24-hour urine collection of aldosterone, potassium in the diagnosis of primary aldosteronism? The role of so the 24-hour collection of urine aldosterone is done as a part of confirmatory test. We ask individuals if there is no contraindication to load salt orally for 3 to 5 days. And starting from the third day, we collect a 24-hour collection to assess aldosterone value together with the urine sodium. And if aldosterone value is above a certain threshold, I think 12 is what is recommended in the guideline, and in a setting of high sodium load in the urine above 200 millimole, then we say that the diagnosis of primary aldosteronism is confirmed. I don't know if I got your question, but another question here: primary aldosteronism in CKD, especially adrenal venous sampling with CKD stage 4, concern for worsening kidney disease due to DIE. Primary aldosteronism workup management in CKD is can be challenging. It's challenging actually, and yeah, that's a concern. But there is a recent data from multiple institutions which compared, it's a retrospective data, but they looked at medically treated patients with CKD and primary aldosteronism compared to those surgically treated CKD and primary aldosteronism, and they show that other than in the bottom line outcome, there was no difference between the two groups, which helps me in terms of when I think about workup and again management in this group. But yeah, that is the concern. Is there any role for using phenrenin to treat primary hyperaldosteronism? I don't think we have data regarding that yet. How can we do the workup in patients receiving several antihypertensive drugs? How should discontinue the drugs? I would not discontinue the medications, antihypertensive medications, especially when I do initial screening. I screen them with no adjustment of antihypertensive medications. But again, if the screening result is negative, then we might need to stop the mostly diuretics and MRA, and then during that time we have multiple medications including alpha blockers, hydralazine, and others to fill in the gap during when they are off. In aldosterone producing adenoma, is isolated resection of the adenoma feasible? I think it's my understanding that that's not a recommended approach. Laparoscopic adrenalectomy is a current recommendation, and we've seen yeah, that's a current, so that's not the approach actually currently recommended. Let's see. In patients with stage 3 to 4 CKD, aldosterone is already raised. How do we interpret and screen such patients? CKD is again difficult workup. Renin would be low because of the kidney function, or high due to problem with excreting the renin. And then so it's difficult. There's no one answer to it. It's the way I look at it. How to proceed with resistant hypertension patients with bilateral nodules between 1 to 2 centimeter. I guess in this case, the workup is the same. I would work them up the way I would work any other patient for primary aldosteronism, perform adrenal venous sampling. But if there is an adenoma more than, I think, 1.5 centimeter, I will do a cortisol suppression test or the dexamethasone suppression test to make sure that there is no autonomous cortisol secretion. Because if there is excess autonomous cortisol secretion, then actually taking care of the nodule or the adenoma that is producing that precedes from before treating the primary aldosteronism. Otherwise, in bilateral cases, bilateral adenoma, I think we do adrenal venous sampling and take care of actually the source of, if it lateralizes, we take care of the source. So we have 1 minute. And again, I just want to leave you best practice alert, some potential there. Consider repeat screening, MRA, if I clinical suspicion. If screening is negative, as plan B, we can treat. And then negative confirmatory test is not definitive PA exclusion. And MRA treatment should be optimizing, all these parameters, not only blood pressure, but looking at non-suppressed renin. Because it prevents complications and mortality. And then again, short history, no vascular damage is the key. No vascular remodeling and kidney damage is the key for a complete clinical remission. So early diagnosis is critical. Thank you so much. It's I think time to stop. Thank you so much again for joining us today. Bye, everyone.
Dr. Scarlett, have a wonderful day.
Thank you. You too. Bye.
Bye-bye.